It's November 11th, 2024. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. A lot to cover this week. We're going to talk about holidays, hand surgery, and diabetes drugs for arthritis patients. I saw a report this week on one of my favorite subjects, and that is after you fail the TNF inhibitor, do you keep going or do you switch? Do you change within the class, or do you swap classes to another MOA? We've talked about that before. I'm a big believer of one and done with TNF inhibitors with RA, and another report surfaced this week about the same practice in psoriatic arthritis patients. And yes, it turns out that it is better to, instead of cycle, to swap to another MOA to get better responses. And in this case, it was instead of going to another TNF inhibitor, that you would switch to an IL-17 inhibitor, and that seems to work. Again, my rule of thumb is if you were, number one, a primary non-responder, you should definitely be changing to your MOA drugs, right? But that if you failed secondarily, meaning they responded initially and then they lost response, or maybe if you've had a toxicity, you could stay within the class. But again, the safer move, the no-brainer move is to change because you've got lots of choices, whether it's in the world of psoriatic arthritis or rheumatoid arthritis or spondylitis, etc. You know, a few years ago, I was invited to be an advisor to the company that was making the collagenase injections for Dupuytren's contracture. And their hope was, well, rheumatologists see Dupuytren's contracture. You know, they can do this procedure just as well as the hand surgeons. Well, this became the topic of a New England Journal report this past week, where they specifically looked at surgery versus collagenase injections. And this was a study of almost 600 patients randomized to either the collagenase injection group. And again, you know, that you find the nodule, you inject the nodule directly. You're supposed to slam it with a Bible, which could make a bloody mess, and may have to repeat the procedure. So in this study, that there was really no significant difference. This was a non-inferiority trial, and it was basically not significant, meaning that one treatment, collagenase injections, was not inferior to limited fasciectomy. Maybe the collagenase did a little bit better, but the collagenase also had more need for reintervention compared to the limited fasciectomy, 15% versus 3 or 4%. So again, what do you advise your patients? One, don't let a rheumatologist do this. Two, send them to a hand surgeon who has experience with this. I tend to go with their expertise. Some are married to the surgery. Some are willing to do the new technology, which is the less invasive collagenase injections. A recent study looked at predictors in patients with MDA5 autoantibody dermatomyositis. A study of 168 patients found that the predictors of all-cause mortality. Now, that's a bad subset of dermatomyositis patients, mainly because they get that rapidly progressive lung disease, which much more so than you see in many of the other variants, including the anti-synthetase syndromes. So they found the predictors of 6-month all-cause mortality was, number one, IL-6 levels greater than 13 picograms per ml, lymphopenia less than 500, being older, and a high LDH. Sounds reasonable. I've been seeing some of these MDA5 dermatos, saw them actually 20 years ago, didn't know what to call them, didn't have the blood test, but more recently have seen them, and I do worry about this subset. And so much so that I am now in favor of doing myositis-associated autoantibody testing, not just for the anti-synthetase, JO1, etc., but also for this recent set of MDA5 and NXP2, etc. I think it's worth noting this kind of data. The STAR study was a recent study that sought to look to assess something I wouldn't have done, which is the better way of getting off of prednisone, which is something, of course, we're not very good at doing. And in this study, they looked at patients who were on, I think, 5 milligrams or more of prednisone, and they either did a prednisone taper or the alternative group were switched to hydrocortisone 20 a day, and then they tapered that to like 10 and 5 and then off. And they looked at the success of discontinuing the steroids and then how well tolerated it was. And it turns out that one was not better than other. I mean, and I've never switched my patients to hydrocortisone with the hope of tapering them. But at 12 months, discontinuing glucocorticoids was 55% in the hydrocortisone group and 47% in the prednisone tapering group, not significantly different. But then again, not all that successful, right? I mean, if you really want to get off prednisone, you're going to have to work at it. It's a lot of education. And getting half the patients off of steroids, to me, means you failed. So this is something we have to struggle with. And my best advice is two things. One, prednisone being prescribed to inflammatory arthritis comes with an expiration date. I'm only giving it to you for this number of weeks or months. And that has to be clearly explained to the patient. You got to live by that promise. Second, you don't prescribe steroids unless you tell them you're going to get fat, ugly, acne, stretch marks, fractures, infections, bizarre infections, serious infections, heart attacks. Just basically lay it all on them, and they're going to be like, "Oh, dude, why are you giving me that medicine?" And then now they're motivated to get off it. Again, something I do with some success, although it's not 100%. Again, we have to work at this. A recent report looked at proteinuria associations with patients with proliferative lupus nephritis, 249 patients. They had longstanding lupus, and the average degree of proteinuria in this cohort was over 2 grams. And what they showed was that the patients who had low levels of proteinuria were more likely to achieve steroid withdrawal, I guess, or renal recovery, not steroid withdrawal, renal recovery. So that was achieved in 71% of patients who had basically 79% of patients who had 1 gram or less. About 10 points lower in people with 1 to 3 grams, and a lot lower in patients with greater than 3 grams who had the worst outcomes. So lower levels of proteinuria, again, more common, very common with proliferative disease, better prognosis, bottom line. The question that I often wonder about is what happens to patients who get referred for psoriatic arthritis. I got a lot of experience and a lot of data about patients with arthralgia who may be considered as having future RA for whatever reasons, serology, family history, or whatever. This is a study of almost 1,400 patients who were referred to rheumatologists. Of the 1,400, they looked at patients who met criteria for inclusions. That was about 10%. And then the ones who actually developed PSA within 1 year. And that was only 35 out of the 1,400. The predictors of patients with psoriasis who were going to progress to psoriatic arthritis, and that is about a 20 to 30% progression rate, included those who had 1, a family history of psoriasis, 2, ultrasound, synovitis, or enthesopathy on ultrasound, and thirdly, lower tender joint counts. So if you have really severe polyarticular problems, it could be a whole bunch of things, including not inflammatory psoriatic arthritis. I thought this was interesting. Another study looked at the correlations between the extent of skin disease, psoriatic arthritis, psoriasis, as measured by the Psoriasis Area Severity Index, or the PASI score, and the clinical variables of psoriatic arthritis. And what they found was that PASI score didn't correlate very well with usual PSA clinical variables and outcomes. I found that surprising. But then again, this was only a 76 patient study. They had well-established psoriasis, almost 216 months, etc. Those who had PSA ultimately was half that amount in disease duration. But they found that the most significant correlation was between PASI and enthesitis. And I like that, and I agree with that, and I've seen that before. But I got to say, this study doesn't say what the literature says. And that the more severe the cutaneous psoriasis involvement, the more likely you're going to get psoriatic arthritis, and the more severe it can be. I remember this because when I was a fellow, I had this argument with the chief of dermatology who made this assertion, and I found a paper or two that argued against it. But ever since then, that was 1985 or 86, I've seen a whole bunch of studies that really confirm that the severity of psoriasis increases the risk, and maybe also the severity of getting psoriatic arthritis. I do like this point that PASI does correlate with enthesitis, and enthesitis is a psoriatic arthritis severity marker, is it not? The journal Chest this week looked at airway disease in a cohort of 188 RA patients who did not have interstitial lung disease or disease or baseline respiratory problems. And they found that when they looked for airway disease by a number of different measures, they got different kinds of measures. So by airway obstruction on PFTs, 21% of RA patients were abnormal, more so in older males who were smokers. Chest X-ray abnormalities were more plentiful, 61%, most of those being bronchial thickening or bronchiectasis, 55 and 12%. And that was more so in patients who were seropositive. But that the thing that correlated best ultimately with respiratory symptoms was quantitative CT scanning. So, and their point was that maybe, and this was a pulmonary journal, right? The chest, probably talking to pulmonologists, but maybe the advice for rheumatologists is that maybe you should be a little quicker to do quantitative CT scans in patients who have respiratory symptoms or who you suspect. Again, you might suspect that in patients who are seropositive or symptomatic. Yeah, you should do PFTs and a chest X-ray. Look for other causes of their pulmonary problems, including TB, etc. But maybe ordering more quantitative CTs, because that might give you more prognostic information. JIA, a nice report in Arthritis and Rheumatology this week about the 20-year changes in DMARD use in juvenile idiopathic arthritis. And I think this parallels the 20-year changes in RA as well. That basically in these last 2 decades, there's a rising use of the newer biologic and targeted synthetics, coupled with a decline in conventional DMARD use. So conventional DMARDs, methotrexate, hydroxychloroquine with sulfasalazine, 90% in 2001, but by 2022, this had dropped to 43% in this large cohort of JIA patients. That was very significant. In the same era, biologic DMARDs increased from 10% to over 50%. Very significant. Most common biologic being used that grew in this time period was from 2007, adalimumab grew from about 7% to about 20% by 2022. Etanercept use declined significantly from 28% to 4%, and I'm not sure really why that is. Maybe because etanercept prescriptions were maybe first to be used, and now other drugs coming along the way, adalimumab being second to etanercept, and then other biologics. And then in the same era, when etanercept is dropping, you're seeing more use of ustekinumab, secukinumab, and abatacept that account for about 17% of all new prescriptions by 2022. What happened with the JAK inhibitors, and they only put data in here about tofacitinib, that went down, rose from 2.9% at approval to 5.2% in 2021, but by 2022 that had dropped or almost been cut in half, and that's due to the safety warnings, etc. So again, I think that this is what you're using, at least as counted by these authors in this study. I found an interesting study this week about myelitis and rheumatic disease. I've seen good cases of myelitis in my practice over 40 years, probably half dozen. In their study, 41 patients, most of them were women. The most common cause was lupus, 41%, Sjogren's, surprising to me, 24%, undifferentiated disease, 15, overlap disease, 12, and a few with antiphospholipid syndrome. The interesting thing about this report was when they looked at those, half of them had antibodies to aquaporin 4, which is associated with the neuromyelitis optica spectrum, right? NMOSD, neuromyelitis optica spectrum disorder. And that some of them, also 7%, had this other myelin oligodendrocyte glycoprotein autoantibodies, and that's the MOGAD. That's a myelin oligodendrocyte glycoprotein associated disease. These are syndromes well known to the neurologists. This article appeared in Neurology, Neuroimmunology, and Neuroinflammation, and they are trying to remind us that if you see myelitis, maybe you should be doing the aquaporin 4 autoantibody test. When that's present, 90% of them had extensive spinal cord lesions. Or maybe you should do the less common, but nonetheless found, myelin oligodendrocyte glycoprotein autoantibody. I've never done those, never considered those. Now I will. Our last two reports have to do with rheumatic disease and diabetes. What happens when you use the diabetes drug? The first is a report about the use of the sodium glucose cotransporter 2 inhibitors, or the SGL2 inhibitors, in lupus patients. And this was claims data analysis where they compared 2,000 plus lupus patients with type 2 diabetes who started on the SGLT2 inhibitors, and another 2,000 who started on the dipeptidyl peptidase 4 inhibitors, DPP4I drugs, and they compared outcomes. And so obviously these drugs, these diabetes drugs, were being used for secondary prevention of diabetes complications. And in this lupus cohort, that was in fact found, meaning a 50% significant 50% reduction in acute kidney injury, a 40% reduction in chronic kidney disease, a 60% reduction in end-stage renal disease, and a 28% reduction in heart failure, and a 10% reduction in emergency room visits. What they did not find in this claims data analysis was a reduction in all-cause mortality, MI, stroke, or hospitalizations, or lupus nephritis. So the good news is lupus patients who need to go on a diabetes drug, the SGLT2 inhibitors are great options, and fare better than the DPP4I drugs. I think that's important to note, and I think that we'll see more of this research going forward. So much so you might see these drugs being used in patients who don't even have diabetes, right? Because all these outcomes, chronic kidney disease, acute end-stage renal disease, heart failure, heart outcomes, etc., are as meaningful to lupus patients as they are to diabetics. This week, New England Journal had an interesting report about the Wegovy drug, semaglutide, the GLP-1 inhibitor, and its effects on knee OA pain. So this appeared in yesterday's New England Journal article. It was a study of 400 obese patients with diabetes who had, I believe it was severe OA of the knee or moderate to severe OA of the knee. These patients were 56 years at entry as far as age, a BMI of 40, a mean WOMAC pain score on a 0 to 100 scale of 70. 80% of these patients were women. The outcomes at like week 68 was a 13% reduction in body weight, 13.7% with Wegovy versus 3% with placebo. And that resulted in a reduction in WOMAC pain score of minus 42 points versus minus 27 points with placebo. That means that, again, they started out with 71 points. They went from 71 out of 100 in pain down to 30 out of 100 in pain. And that was much better than the placebo. In an accompanying editorial, David Felsen from Boston pointed out that we know this. We know that substantial weight loss results in a dramatic reduction in pain. What we don't know is that these GLP-1 drugs, are they exerting an effect beyond what they do with weight control? Are there other anti-inflammatory immunologic effects? And the only way you're going to know that is by testing GLP-1 receptor agonists in patients who aren't obese, and to see what it does as far as their pain, even though they may have moderate to severe knee OA on X-ray. That's the study I want to see. Again, these drugs, whether it's the SGLT2 and the GLP-1s, are going to be big players in the field of rheumatology going forward. And I think we're going to see a lot of combined therapies with those drugs being used with our drugs, and looking at combined outcomes, your arthritis outcomes, the weight outcomes, the hard endpoint outcomes. And that's really, I think, the point I want to make on this. It's one thing to talk about pain. It's one thing to talk about a reduction in CDAI or swollen joint count or DAS score. It's another thing to talk about the things that really matter: hospitalizations, death, the need for major surgery. Those are the hard outcomes that I want to see with these really big, important studies going forward, because this is going to dramatically increase the cost of care if we start using GLP-1 drugs or even the SGLT2 drugs in our patients who are already getting expensive care, right? And the disease itself is expensive. But if the outcomes are dramatic, well, then it makes sense, does it not? Let's consider that. I want to remind you, Room Now Live 2025 is coming up. We already have 100 of you who are registered for this. That's about 20% of what's going to actually show up. Now's the time to register at roomnow.live. I want to end by saying happy Diwali to all of our Indian colleagues. Diwali is the Hindu festival of lights. It's a 5-day celebration where there's a lot of festivities, fireworks, feasts, and prayer. And I know Diwali well because when I was chief resident in New York, my job as chief resident was to make sure everyone was happy. I had to make sure that the Orthodox Jews got their holiday. I had to make sure the Christians got their holiday. I had to make sure that our Indian physicians got Diwali. And there were a few others thrown in there. I learned to like all these holidays because I felt it was another chance for me to ask for the day off as well. And when I didn't get it, I could at least rejoice in the happy smiles of those who returned from their Diwali holiday or from Rosh Hashanah or from Easter or whatever. Anyway, happy Diwali. We'll see you next week.